Hey there, Dr. Avinash here. This video is about histamine and antihistaminics. Now, as far as pharmacology is concerned and your upcoming exam is concerned, we are more interested in the antihistaminic part of this particular chapter. But I believe that without understanding histamine and its receptor, you will not be able to understand the functions of antihistaminics. So, first and foremost, let us talk about the histamine and its receptors. Okay, histamine is histose tissue amine. So this is a tissue amine. It is present almost in all different types of animal tissue, even in certain plants and all. You get it. There are 4 types of histamine receptors that have been recognized, just like alpha and beta adrenergic receptors. Histamine receptors are classified into H1 and H2 receptors. H1 was the one which was blocked by the older antihistaminics, and later H2 blockers came, and that's how we know that there are 2 different types of receptor. Now there is a third H3 receptor, which is an autoreceptor which controls histamine release from the neurons in the brain. Okay, now there are some selective H3 agonists, but there is no clinical application for that. Okay, and there is an H4 receptor. Don't know whether really it is a separate receptor or just a modified form of H3. Now this is a table that I want you to pay attention to. The H1 receptor is located on the smooth muscles of the intestine, airway and the uterus, and when histamine attaches to the H1 receptor, it causes contractions of the muscles of the intestine, the airway and the uterus. That's the reason why in allergic conditions histamine causes bronchospasm, right? It will also cause intestine to undergo spasm. Now as far as the blood vessels are concerned, there are different ways in which histamine can work. If histamine directly works on the smooth muscles, like what it does in most of the large blood vessels, it causes vasoconstriction. But in the smaller blood vessels, it acts on the endothelium and not on the smooth muscles. By acting on the endothelium, histamine via its H1 receptor will release nitric oxide and prostacyclin. PGI2 is prostacyclin, and both these substances cause vasodilatation, because of which the gaps between the endothelial cells increase and there is increase in capillary permeability. Simple. The afferent nerve endings are stimulated, the ganglionic cells are stimulated, the adrenal medullas release catecholamines and the brain fires impulses. Now imagine a medicine which is anti-H1. When there is anti-H1, you relax the airways, intestines relax, uterus relax. The smaller blood vessels will not undergo vasodilatation. There will be no capillary permeability. There will be no vasoconstriction in the larger blood vessels. Getting the idea, right? So everything that I have marked here, because of H1 antihistaminics, all these actions will be reversed. Let's talk about the H2 receptor. For us, the most important thing is it's present on the gastric glands and it aids in secretion, acid secretion. H2 receptor blockers, that is H2 antagonists, have already been covered in another topic in details in GIT. Okay, so we are not going to discuss H2 blockers at all. But even there you will realize that it will dilate the smooth muscles. It will have a positive chronotropic and positive ionotropic action. This is the action of histamine, right? So when antihistaminics, H2 antihistaminics work, the acid secretion will decrease. There will be no vasodilatation. There will be no positive chronotropy, which means the rate of firing will decrease. No ionotropy. And brain still has the postsynaptic impulse. The most non-important receptor, of course, is H3 from our pharmacology perspective. Okay, it's present in the brain as a presynaptic controller, so that unnecessary histamine release is not happening. This causes sedation. It's present on the lung, spleen, skin and gastric mucosa. H3 receptor actually decreases histamine release. So if you block H3 receptors, there will be increase in histamine release. In ileum, it inhibits acetylcholine release and decreases peristalsis. So when you give anti-H3, peristalsis will increase, and certain blood vessels, it can inhibit noradrenaline release and cause vasodilation. Now I want you to do the first column and the second column perfectly so that there's no confusion. I don't want to waste your time in explaining something that is never going to come in the exam, especially in this video, because I am very exam focused. Simple. So all these topics you can easily skip, okay? But if you do have some time, like maybe you're having your breakfast or just munching on something, like relaxing a bit, that time you should have a look at gastric, this pathophysiological role, where it is explained how gastric secretions are enhanced, how allergic phenomena happen, how it works like a neurotransmitter, and how it is a part of inflammation. Now you already know this from other areas of your subjects, like in pathology you have already studied role of histamine in inflammation, gastric secretion in GIT, pharmacology we have already done, in allergic phenomena again from patho, you know it. So you know these things, you just have a look at it and be done with it. Simple. Which brings us to the conventional antihistaminics. These are something that you must know. These drugs competitively antagonize action of histamine at the H1 receptor. Okay. Now, please understand that H1 receptors will have different activities. Okay. At different sites. Sometimes they act like inverse agonist. They will reverse the action instead of just blocking. See, antagonist means blocking the action. Inverse agonist means creating an exact opposite action, like histamine. So ulta of histamine, like reverse of histamine, would be inverse agonist. Simple. Now the first antihistaminics, the first generation ones, they could cross the blood-brain barrier and they had some CNS effect. Then H1 antihistaminics that we use now, they are less sedating or non-sedating, and they are called as second generation H1 antihistaminics. Okay, let's talk about H1 antihistaminics. All of them have similar actions. Quantity wise it might differ, quality wise they are same. Simple. Qualitatively all have same action. They antagonize histamine. Okay, so what does H1 receptor do? Block that. Block histamine induced bronchoconstriction, block contraction of the intestine, block contraction of other smooth muscles, block the triple F response, so wheal, flare, itch goes away. Fall in blood pressure that happens because of histamine is blocked. Right? You want complete blockade, you need to give H2 antagonist also, because both of these H1 and H2 receptors are important for maintaining blood pressure. Now if you pre-treat an animal with H1 antihistaminic and then you give a large dose of histamine, the animal will not die because histamine will not be able to create its allergic reaction. The release of adrenaline is gone. Constriction of large blood vessel is antagonized. Okay, now not gastric secretion. Gastric secretion is 5-HT2, right? Cyproheptadine, one of the antihistaminic, has additional 5-HT2 receptor blocking activity. Important MCQ. H1 antihistaminics or antagonists will have anti-allergic actions. All or many manifestations of type 1 hypersensitivity will be suppressed. Urticaria, itching, angioedema will be suppressed. Anaphylactic fall and BP would be partially prevented. Asthma does not happen that way. You know why? Because asthma is because of leukotrienes and prostaglandins and many other things. So histamine is not the sole causative factor for asthma. Simple. Of course, different species, different tissue will have different sensitivity. As far as human asthma is concerned, leukotriene and platelet activating factors are more important chemical mediators as compared to histamine. And that's the reason why histamine is not that great. Antihistaminics are not that great for allergies. You need to know this table. This is the classification. The more you know, the better it is. Simple. Okay. The older antihistaminics could cross the blood-brain barrier and attach to the central H1 receptors. And that's the reason why there were CNS depression. Okay, remember H1 and H2 receptor both are causing action potential. They are excitatory. When you block them, there will be inhibitory. Now, please note that each human being has different concentration of receptors, different blood-brain barriers, and as a result, the individual susceptibility to different agents will vary. Same drug, same dose may incapacitate some patients, others will remain alert. So, this table kind of gives you the sedative properties: highly sedative, moderately sedative, mildly sedative, and the second generation, which are practically non-sedative or very little sedation. Okay. Now, some individuals will have a complete reverse reaction. Instead of depression, they will have stimulation like restlessness and insomnia, and sometimes excitement and convulsion will be seen. The second generations are practically non-sedating. That's why we made them. Okay. Now, some H1 antihistaminics are important in motion sickness. If you've gone through the chapter on gastric GIT, we have done anti-vomiting drugs there. You would have noticed anti-H1 histaminics there, H1 antihistaminics there. Now, whether it works by antagonizing the brain histamine, or many of these medicines have anti-muscarinic property, why this motion sickness is blocked, we don't know. Is it histamine blocking property or anti-muscarinic property? We don't know. Promethazine can actually block vomiting of pregnancy and many other causes. Some of these, because they are anticholinergic, right, centrally acting anticholinergic, they can act on Parkinson's patient and reduce tremors, rigidity, and cyalluria. So probably the anticholinergic and the sedative property are beneficial in these patients. The older antihistaminics, especially cyproheptadine, have appetite stimulating effect, so patient will feel hungry more. Plus, some H1 antihistaminics are antitussives, but they are not really recommended as anti-cough medications. Moving on to anticholinergic actions, many of these H1 blockers, they antagonize muscarinic action of acetylcholine, and there is a different classification for that: high, low, and minimal or absent. I would recommend you do this, but at least remember one or two examples from each category, so that in case somebody asks you in your vivas, you are not left blank. If given with atropine, phenothiazines, tricyclic antidepressants, or disopyramide, their anticholinergic action adds up. So be careful when you are giving antihistaminics with all these. The local anesthetic properties of phenyramine, promethazine, diphenhydramine are pretty well known. They are strong local anesthetics, the ones which I mentioned. The other ones have weak membrane stabilizing property. They are weak local anesthetic, but they are not to be used as local anesthetic because they can cause irritation when given subcutaneously. Okay. And BP, most of them will cause a fall in BP on IV injection, but this is because of smooth muscle relaxation or by alpha adrenergic block. But on oral administration, this does not happen. Some people get postural hypotension, others don't. You don't really have to know pharmacokinetics, you just need to know the side effects of these medications. The first generation H1 antihistaminics had side effects, but usually mild, and individuals had different susceptibility. So same levels of side effect will not be achieved in all individuals. Sedation, diminished alertness, concentration is diminished, lightheadedness, motor incoordination, fatigue, and tendency to fall asleep would be the commonest side effect because of the action on the blood-brain barrier. There is impairment of psychomotor performance, which means the thinking part is also affected. Patient can't even think clearly, and hence you should warn the patient taking first generation H1 antihistaminics. Please don't operate heavy machinery, don't use vehicles, otherwise you might just harm yourself and others. Simple, easy till now. Fantastic. Now what you need to understand is the fact that alcohol synergizes with the antihistaminics, which means the CNS depressant action will become exaggerated, so be very careful. But you also know the fact that some people become restless, they are nervous, they are unable to sleep, so both extremes are possible. The good news is second generation compounds are not having these CNS actions, right? So as we go through the side effects, you will realize that most of these side effects are extension of their pharmacological action. We don't give H1 antihistaminics to children because the CNS depressant property may interfere with their learnings and other academic tasks. Occasionally, once or twice is fine, not for long term. Many of these compounds also have anticholinergic properties, right? And as a result, they may present to you with dryness of mouth, altered bowel movements, urinary hesitancy, even blurring of vision. But they are again like the first generation ones. The second generations are pretty free of this. People have complained of epigastric distress and headaches. Local application is known to cause contact dermatitis, so be careful. Some of these medications like hydroxyzine or cyclizine and fexofenadine, they are teratogenic in animals, but as of now in humans nothing such has been observed. Nonetheless, be very careful in giving it to a pregnant woman. Simple. When a person takes acute overdose of this drug, it produces central excitation, tremors, hallucination, muscular incoordination, convulsions, flushing, hypotension, fever, and then something like belladonna poisoning, because these are anticholinergics after all. Death can happen due to respiratory and cardiovascular failure. Now the good news is, after 1980s, second generation antihistaminics started. We write them in short as SGAs for this chapter. Don't do that in your exams. So if somebody asks you compare the first generation and the second generation antihistaminics, you should say the second generation has zero or very little CNS depressant property and has more H1 selectivity, so very little anticholinergic side effects. Apart from this, they also block the late phase allergic reactions by changing or modifying the action or modifying the release of leukotriene, platelet activating factors and other cytokines. Okay. As of now, there is no third generation antihistaminics. Okay. The good news about these, they don't act on the brain, so it has the advantage of not impairing psychomotor performance. So patient can drive, operate heavy machinery, no subjective effects, no sleepiness, no combination. I mean, it does not potentiate with alcohol or benzodiazepines. Of course, some patients will complain of sedation, but the incidence is very simple, very negligible. It's almost similar to placebo. The problem is they have a narrow spectrum of therapeutic usefulness because they only act on one receptor. So the principal indication is more like allergic rhinitis, conjunctivitis, hay fever, pollinosis, where they control sneezing, runny nose. Once the nose is blocked, they might not work. They control that red, watery, itchy eyes. In urticaria or something called as dermographism, where because of allergic conditions, you can literally scratch the skin of the patient and you can write your name on it. There will be like inflammation in the places where you scratch. That's dermographism. And atopic eczema, in acute allergic reactions to food, drugs. But they don't have good antipruritic, antiemetic and antitussive actions. Now, as far as we are concerned, please have a look at fexofenadine. There was this older preparation called as terfenadine. This is the active metabolite, the first non-sedating second generation antihistaminics. The problem with fexofenadine was it caused deaths because of polymorphic ventricular tachycardia. The QRS complex changes, hence polymorphic ventricular because the problem is the ventricles, and tachycardia because the heart rate rises. Torsades de pointes, that's what we call it. Okay. This used to occur when it was given in high doses or when it was co-administered with cytochrome P3A4 inhibitors such as erythromycin, clarithromycin and so on. This was because fexofenadine blocked the delayed rectifier potassium channels in the heart at higher concentration. There was another one which was banned for the same reason, astimizole. Okay. Now fexofenadine has a low propensity to block the rectifier channel, so does not prolong the QTC and minimally metabolize. So all these things that I spoke about was for terfenadine. Because of these, we have kind of stopped giving terfenadine. Fexofenadine does not do this blockade of the delayed rectifier potassium, so it's safer and it is minimally metabolized, so no chance of interaction with cytochrome P3A4 inhibitors. So because it was largely free of the arrhythmogenic potential, we like this drug. Of course, some people might present to you with long QT. So people who already have long QT, chances of them getting ventricular arrhythmia is higher. So not very safe for patients who are suffering from long QT interval or bradycardia or hypokalemia. Now, even though fexofenadine can cross the blood-brain barrier, the crossing is very poor. So hardly anything reaches the brain, minimal sedation, minimal impairment of psychomotor performance, free from atropine side effects. So that's why we love it for this allergic rhinitis, urticaria and skin disorders. I won't do any other drug from here except cetirizine. Cetirizine is a metabolite of hydroxyzine. It has marked affinity for peripheral H1 receptor and penetrates brain poorly. So there is a chance of mild sedation and subjective somnolence. Somnolence is this feeling that I am going to sleep. But apart from that, not much. No cardiac problems, no arrhythmias even when you give it with erythromycin, ketoconazole, nothing like that. Cetirizine has an additional property. It inhibits the release of histamine as well as other cytotoxic mediators, even from platelets, from even eosinophil chemotaxis during the secondary phase is blocked. See, so many things, not releasing histamine, not releasing cytotoxic mediators of platelets, not causing eosinophil chemotaxis. This itself may benefit allergic disorders by so many different methods, right? Plus it attains higher, longer lasting concentration in skin. That's why it's good for urticaria and atopic dermatitis. Plus once daily dosing is good enough. We also give it for upper respiratory tract allergies, pollinosis, urticaria, atopic dermatitis, and it can even be used as an adjunct for seasonal asthma. That's that. Just do this much. Where will we use H1 antihistaminics? Well, we use them in allergic disorders. See, antihistaminics don't block the antigen antibody reaction. They just block the effect of histamine that has been released, right? So they are palliative. They stop some symptoms. They don't cure the disease. They control certain immediate types of allergies like itching, urticaria, seasonal hay fever, allergic conjunctivitis, angioedema of lips and eyelids. All these things are effectively controlled, but their action is kind of slower. So when you have type 1 hypersensitivity reaction, adrenaline would be the drug of choice to give to a patient who is having laryngeal angioedema. Even you give IV antihistaminic, it takes time to work, and hence what is recommended is you give antihistaminic as an adjunct, not as the primary drug. You can't depend on them for anaphylactic shock. They are secondary to adrenaline, and in other conditions like perennial vasomotor rhinitis or atopic dermatitis or chronic urticarias, you have to combine H1 antagonist with H2 antagonist. Okay, only H1 might not really work. Don't give it for a bronchial asthma. We spoke about how leukotrienes and platelet activating factors are more important, and the concentration of antihistamines at the site of inflammation is not enough to block histamine, which is released locally in the bronchi. So one, it does not reach the correct place. Second, even if it does, histamine is not the primary mediator, and hence it is ineffective in bronchial asthma. Simple. Okay, we just spoke about the fact that cetirizine has a role in as an adjunct in seasonal asthma, but that's it. That's the only medicine. They are also ineffective in other humoral and cell-mediated allergies, because in that histamine is not involved. They suppress urticaria and swelling in serum sickness, but apart from that, nothing else. So type 1 hypersensitivity reaction to drugs and all can be controlled by these medications, not the other kind of reactions. Simple enough. Now there are some conditions which involve histamine and antihistaminics might help us. For example, symptomatic relief from insect bite or IV poisoning. That works. Abnormal dermographism, it is suppressed. Even when we give insulin or blood, and that sometimes causes rigors, it can stop those. So prophylactically you can give it before you transfuse blood or saline. All types of itchiness, pruritus. Many conventional ones have antipruritic action, which is independent of H1 antagonism. You don't get 100% relief, but older ones are better for idiopathic pruritus. Simple. Acha, can you give it for common cold? Not really. They don't affect the course of illness. The max they do is symptomatic relief by their anticholinergic and sedative action. So the patient sleeps better, kind of recovers faster, and the anticholinergic action reduces nasal secretions. Newer ones are of course less effective because you want to reduce the secretions in the nose. You better give something that works by anticholinergic mechanisms. The newer ones don't have anticholinergic properties. You can give them in motion sickness, promethazine, diphenhydramine, diamine hydrinate, meclizine. We have done this in some other chapter. Prophylactic value in milder types of motion sickness. Remember to take these medicines at least 1 hour before journey. Once that feeling of nausea sets in, it cannot be stopped. It can be used in morning sickness, drug-induced and post-operative vomiting, also in radiation sickness. Promethazine especially can be used for all that. Many people have used cyproheptadine as anorectic or in anorectic and convalescent patients because it is known to improve appetite. It is not an approved method. Don't use these things. Even sometimes parent comes to the clinic with the complaint that the child does not eat anything, is not gaining weight. Don't use these medications because weight gain might be there, but the patient might not learn anything because there is a CNS depression action. And lastly, we can use it for vertigo. Vertigo is typically a spinning sensation or rotation of surroundings or a sense of movement when actually the patient is not moving at all. Mild vertigo is called as dizziness. Usually it is vestibular origin, but it can be because of many causes. Now we are not really going into the details of vertigo. What we need to know is the drug H1 antihistaminic cinnarizine and dimenhydrinate are most commonly used vestibular suppressants in this condition, and as a result the vertigo will stop. Here they have given you a little description of cinnarizine. You can add that to your answer if you wish. Apart from that, pre-anesthetic medication as its anticholinergic and sedative property will help, but don't require them right now because the anesthetic itself are amazing. Sometimes we give it with cough medications. They do not have cough selective properties. They just afford symptomatic relief by sedative and anticholinergic property. So it really does not make sense to give something for its sedative and anticholinergic property. You give something that works on cough. In Parkinson's, because they are central anticholinergic, it might give symptomatic relief. In acute muscular dystonia caused by antidopaminergic or antipsychotic drug, you give anticholinergics, antihistaminics with anticholinergic properties, parenteral promethazine, diphenhydramines, and hydroxyzine will work. Okay, it is based on their central anticholinergic action. And lastly, we can give it as sedative, hypnotic, and anxiolytic because they are sedative and induces sleep, especially in children. We can do that. Problem is promethazine produces serious respiratory depression in children. Even deaths are on record, so you have to be very careful not to give it to any child below 2 years of age. And again, they are not sleeping pills. Benzodiazepine should be the drug of choice. Okay. Apart from that, hydroxyzine has been used occasionally in anxiety that has autonomic manifestation. Like some people, when they get anxious, they have like palpitations and they even get loose motions. For them, it might work. H2 antagonists are cimetidine and ranitidine, to be covered in some other chapter, and H3 antagonists are currently of no use to us. This completes our chapter on H1 antihistaminics. I hope you have understood this. Let me know if there is any doubt. I will be more than happy to help you. Till the next time we meet, this is Dr. Avinash signing off for now. Take care, keep studying and keep rocking. Bye bye.